Hello, everyone. Welcome back. Let's take a look at a high-yield nephrology question. We've got a 43-year-old man who's here for follow-up after being diagnosed with PSGN. Initially, he had gross hematuria, edema, and hypertension. He needed a diuretic to manage his symptoms. 12 days before this all started, he had acute pharyngitis, which resolved on its own, so no antibiotics were given. At diagnosis, his serum C3 was low, and his anti-streptolysin O titer, the ASO, was elevated. So this is a pretty classic case of PSGN. Now here's the actual question. Which of the following factors most likely indicates a poor long-term prognosis for this patient's condition? Let's go through the options. A, age at diagnosis. B, associated hypertension. C, delay in corticosteroid treatment. D, elevated anti-streptolysin. O titer E, gross hematuria. Take a pause here. Think about which factor really predicts a worse long-term outcome. All right, if you picked A, age at diagnosis, you're right. So, starting with the pathophysiology, PSGN usually happens several weeks after a group A strep infection. That could be something like pharyngitis or impetigo. What actually happens is this. Immune complexes get deposited in the glomerular basement membrane, or GBM. These deposits trigger an immune response leading to activation of complement, especially C3 and the CH50 pathway. Now let's talk about the clinical features. Some patients can be completely asymptomatic, but if symptoms do show up, here's what you might see. Gross hematuria, that means visible blood in the urine, and it's often described as tea-colored or cola-colored. Edema, this can be periorbital, especially in the morning, or generalized swelling. And hypertension, which is pretty common in PSGN due to fluid retention. Moving on to the lab findings. On urinalysis, you'll usually see positive for protein, positive for blood, and sometimes red blood cell casts in the blood work. You'll often find elevated creatinine due to impaired kidney function, low C3 and CH50 because the complement system is being used up, and sometimes C4 can also be low, but it's not always affected. For most patients, supportive care is the main treatment. There's no specific medication that reverses the disease. It's all about managing the symptoms while the kidneys recover. If there's volume overload, like swelling or pulmonary edema, we use loop diuretics like furosemide to help get rid of excess fluid. For hypertension, we may need to add on antihypertensive medications, depending on the severity. And in rare severe cases, if kidney function really declines or there's fluid overload that's not responding, hemodialysis might be required. In children, PSGN usually resolves on its own. But in adults, the story is a bit different. Studies have shown that adults are more likely to develop chronic kidney disease after PSGN. So, age at diagnosis is a major prognostic factor. Let's clear up a few important points about the wrong choices. Gross hematuria and hypertension. Yes, they're classic signs of PSGN, but they don't predict poor outcomes. They're just part of the clinical picture. An elevated anti-streptolysin O, ASO titer helps confirm a recent strep infection. But here's a catch. If the patient was treated with antibiotics, or if the infection was on the skin rather than in the throat, the ASO level might be falsely low. So it's useful for diagnosis, but it doesn't affect prognosis. Now, what about corticosteroids? They are not used in PSGN. They are actually used in conditions like minimal change disease, which causes nephrotic syndrome. That's the one with heavy proteinuria, edema, and hyperlipidemia.